thank you. It really is a great pleasure to be back. I arrived yesterday, so I'm not a little jet lagged. A lot jet lagged, but I speak better when I don't know what I'm talking about, so it's okay. I left about 3 months ago, and I left because I had to attend the Diamond Jubilee, where it rained worse than it did today. Rods, but I was there waiting for the Queen to pass in the boat and all that sort of stuff. And it went extremely well. And then, of course, I had to be there for a fantastic performance at, you know what, called the Olympic Games. In fact, it's caused us a bit of a problem in the UK because we planned that every single person who won a gold medal would have a stamp issued the very next day to be used on postage, postage stamps. And that in their town, every pillar box, would be painted gold. But we only expected 18 medals, and we had 32. So that means we lost a lot of gold reserves, number one, by painting all these pillars. And secondly, we thought they wouldn't get the stamps out on time. But they did, and so we're very proud of that. So it's nice to come from Great Britain with a good story rather than the usual stories of, oh my God, but anyway, brown bags. It was Pam who first said to me we should have a brown bag session, and I thought, as some of you may know already, I thought that meant we would go out drinking, put the liquor in the bag, and then we see what you're doing. But obviously it was one where people came along at lunchtime and had sandwiches. And this was so successful here that we started doing them in the UK, well, in Cardiff to start off with. And we call them the Pan Muth. Muth, I can never pronounce the surname. Muth. Pan Muth brown bag session. And they go very well. Now I'd like this to be a brown bag session because I don't want to talk to you about what we all did. At least I don't want to talk a lot about that. What I want to do is to try and get you to think along the lines that we were thinking when we actually produced these papers. And I'd like an interactive session if you don't mind. I know it's a Monday morning and all those sort of things, but can we do that? Because why should I talk to you about the first paper, which is a case for change, which is addressing the key challenges that confront not just New Zealand, but indeed all developed healthcare systems in the world. And as some of you may know, we're doing the same sort of thing in Wales and with the Bevan Commission, which I should be talking about later as an independent commentator panel, which has helped a lot. And indeed, they picked this up in Scotland now. So we're all looking at this in a different way. And of course, in England, they're also looking at it, but they're looking at it in a very, very different way. So different that nobody knows what's going on at all in that area of the country. So what I'd like to start off by doing, if you can bear with me, is let's ask you, some of you may have seen the Case for Change paper, but even so, I want you of you, please you of you, let's have the 5 key challenges that we must overcome in a healthcare system, in a health system, and indeed in systems in general, but let's focus on New Zealand and on the healthcare system. What really are the key challenges? This isn't going to be difficult, but then I want to, having said that, I want to say, how do we best attack them, and win the game? So can somebody start off and say, right off, number 1, what is the main challenge that we have to ensuring that we have, as Geraint says, and I believe Geraint, he's not a prophet, but he's near a prophet, and he's prophesied that this County Manukau District Health Board will in fact be the best in class by 2015, is that, or was it 16? Right, really? Still sticking to 2015? When? December. December the 7th. The day they bombed Pearl Harbor. That would be a lovely date, right? So, December the 6th or 7th, 2015. Best in class, world class, delivering a system which is of such a quality that it is comparable to or better than systems elsewhere to which it can be compared. Righto, so to do that, what is it that we have to do to actually achieve that? Number 1, what is the key challenge we have to overcome? Yes, sir.
Education.
Pardon?
Education.
Could you
Population
elaborate?
education, health literacy, and complexity.
Education.
Understanding complexity.
Okay. Education, understanding complexity. Is that complexity within the healthcare system itself, or within society?
Understanding systems.
Understanding systems, that's good. Right? So complex and understanding them, and by understanding them, being able to use them, or revise them, or modify them, or abolish them, as we think necessary. The lady from public health in the back.
Health inequalities.
Sorry?
Health inequalities.
Health and quality.
Health
Inequality.
inequalities.
I'm getting used to your accent again, okay? Health inequities and inequality. What do you do about it?
How are we actually going to be best in class unless we actually do something about them? We will never be best in class.
I think underpinning all of that is overcoming ourselves.
So it's getting over it. So.
You know,
we have this one saying, which goes back to what that gentleman said earlier. Some people say, we don't need to change systems, we need to change people, irrespective of systems. I mean, that's one element of the argument. I think there's a mixture of both, but you're right. I mean, what you said is overcoming ourselves, being different people, or thinking differently.
Scarce resources and considering opportunity costs and prioritisation.
Yeah. So, can I call that sort of financial challenges in general? Yeah, are there? You said inadequate resources, is that what you said?
Yeah.
And being able to prioritise, to be more efficient and effective. Yeah. Affordability. Affordability. That's fair. So 6 is we've got 4. What else is there?
Workforce.
Sorry.
Workforce.
Hello. Nice to see you. Nice to see you back. Yes. What about our workforce though?
Just reconfiguring it, relocating, that change management that's got to go into our workforce as far as new models, new ways of thinking to meet all the other challenges.
Yeah.
I don't think we'll be best in class until we put the patient front and centre and actually not pay lip service to patient family centre care, but actually make that the way that we are.
I hate using the word patient focus and patient centered. So supremacy, the supremacy of
yeah, patient centered is different to patient focus. I mean, we do a lot of patient focus.
It is, yeah.
But actually putting the patient in a position of power and decision making, I think is what I'm talking
So the patient, I had a big argument recently, that's why I'm going on with this. I kept on using the word patient in a recent paper for the government, which is called Together for Health, which is based upon a response to recommendations made by the Bevan Commission, the Independent Commentator Panel. And I kept on using the word patient. And a lot of people said, you mustn't use the word patient, because if you use the word patient, then you're focusing only on healthcare. And I thought, yeah, I do see that. So they said use the word citizen. So I used the word citizen in some of the sentences where I put patient, and it don't make sense. On the other hand, I do learn, even at my age, I do learn, and I put the word patient where citizen perhaps should be in when we talk about public health and community health, and it didn't work either. So I think we've got to use both of them. You know, so we've got to be patient and family-centered. That's another phrase. We've got to be citizen-centered. But when the person comes into hospital or into the healthcare system, I still feel more comfortable in talking about patients. It doesn't demean people, you know, in the same way as I still don't mind being called a British subject, you know. If I call myself a British citizen, I expect somebody to come along with a guillotine and start chopping people's heads off. So I don't like using the word citizen. Citoyen. Anyway, right. That's what have we yes, culture? Pardon?
Culture. I mean, it sits on several of them.
You're anticipating. What?
He's read the paper.
He's read the paper. No, but he is, yeah, I know what you mean. But we should say that. I think we should say, put down culture. Another one, and then we get on with a bit more. Just one more. Anything else? We talk about key challenges and millions of things we've got to do. Key ones, yes.
talking about a unity of purpose. It's kind of how do we get everyone aligned and moving in the same direction?
Okay, that's another one on the side there, right? Okay, because my next question is, during the almost 4 months that I was here, it didn't take very long for us all to agree, different wording, that these were the prime. They are the prime key challenges. They describe it in a different way, and we try to hone some of them into one into, you know, 3 or 4 into 1. But basically that's it, and it's not difficult. And I was in British Columbia for a few days in Vancouver before I came here. I talked to them about the same thing in the University of British Columbia. And they came up with exactly the same challenges, but they had a challenge which you have, and they have, and we don't. And it's one, you know, you've got to talk about. So what is it? What have they got in British Columbia and in New Zealand that we don't actually have in Wales or Great Britain to any significant extent?
Indigenous.
Yeah, come on, let's talk about it, you know, because this is the point, you know, when you start talking about this, people just say, it's nothing, you know, it's a wonderful thing to have an indigenous population. I am the indigenous population in Wales. In Wales, he's the indigenous population. He's not, he's from England, right? And the point is, we, the Welsh, we're the Britons, the indigenous population, so we know what it's like for about, except for the last 100 years, to be persecuted and nobody taking a blind bit of notice of us. And so what happened? All the Scots and the Welsh and the Irish went everywhere else. And they created places like New Zealand and America and all that. But anyway, that's a bit political. No, you have got a problem, right? And it's a problem, as far as I'm concerned, as an outsider, in the same way you've got a problem whereby there's an indigenous population who have got high morals, high ethics, a way of life that is, and I mean this because I went and did my Dihanga training in Marae, and I speak Tenakato, yeah, you know, I speak that a little bit, not a lot. And I think it's a wonderful thing, and it must be preserved, and the ways of getting that blend and that culture and that taking that forward in healthcare in particular was very well demonstrated in the Dihanga sessions. We didn't have that, or at least when you look at it, that's what the people in British Columbia told me. They said, look, we've got a First Nation, that's what they call, what the other people call American Indians, a First Nation, and we think that that's the biggest stumbling block that there is to progress in these areas because of certain health inequities, you know, in those groups. But actually, when you think of it, and you look at Britain, although we haven't got that indigenous population as British Columbia have, it's exactly the same, because we're not tackling problems within the indigenous population, because those problems are equally present in the population that came later. We're looking at health inequities, we're looking at deprivation, largely. We're looking at social exclusion. We're looking at all the things that give rise to poor health. So, although I started off by saying you've got a different context, you really haven't, I don't think. You've got to address some of the issues, but, sorry.
I just suggest that I don't know, there are some of the Māori health team here, but they wouldn't actually want to be labelled a problem. I think that they would want to be seen as a strength. Exactly.
But when you get the, I'm not saying I haven't seen that here, but I was in British Columbia, and it was a problem. That's what I'm saying.
I think at the beginning
it's
you
not,
we have a problem and they have a problem,
it's
and
not
I
a
think we
problem.
have to be really careful about how we...
It's not a problem, yeah. Well, I'm deliberately being provocative by using those words, because it's not. Coming on and say it's not a problem. And it's no different to any other culture. And indeed, if anything, when I went to and met a lot of people in the Tikanga and Marae and all that stuff, I found that actually a lot of the things that were being brought to that area of healthcare were actually benefits more than we could deliver. When I say we, I'm talking about Britain now, because we haven't got that culture. So it's not a problem, I agree.
I think you're absolutely right. I think there's a, you know, say for example, the Whānau Water Program is a Māori-based program,
yeah,
but it's got transcultural principles, you know, that actually would fit very neatly, you know, to my sort of Polish Jewish background.
That's right. Yeah.
Or, you know, perhaps Jonathan's Yorkshire background. You know,
yeah, Yeah.
But but it's the principles that underpin it. They're very transcultural, actually. We have got a lot to learn from them.
Absolutely. And since I've been here, I got involved in growing up in New Zealand, which I didn't know much about. And I've been reading nearly all the reports that have been written about growing up in New Zealand and find that coming through, you know. There's a lot of problems. In the generic sense, there are problems, challenges, but actually, the whānau, is that the right word? The whānau, the approach to, it's beyond just family, isn't it, whānau? That's a real benefit that can be well used. So, sorry, yeah.
And along the same lines, I think I like the developing view that rather than look at it as a problem or in your community, it's not what are their needs. You're looking at what are the assets there, how are you going to tap into those assets to then develop those. It's sort of a different approach, a more positive sort of approach that is far more helpful for the big problem that we're trying to do.
Yeah. Somebody should put it on as well.
I just think we also have to look at ourselves and think that, actually maybe the problem is that we haven't really worked out what working in a treaty-based framework actually looks like. And it is about acknowledging the strengths model, but it's also about questioning ourselves about how well, so the problem might be framed as actually our problem about how we have not worked in a treaty-based framework to actually address some of those issues.
I agree, but we mustn't, walk away from something else, and that is we get deprivation, we get obesity, we get alcoholism, we get excessive smoking in the UK, and I've been comparing, sort of figures we've got, and they're not, when we talk about the deciles, deprivation, we're not much different.
Except that we have an additional, so we've just done some life expectancy, because this is coming up actually in terms of localities planning about actually should we be just looking at decile or ethnicity or both, and that actually if you take somebody who is Pākehā in the most deprived decile from a socioeconomic perspective, they still actually do better than Māori who actually live in the least deprived kind of space. So there's an additional, it's not just about socioeconomic.
Can I just, thank you. Again, I'm glad you anticipated my next bit, because there's a paper that appears in the Journal of Occupational Medicine last month, which is looking at this particular issue and found the anomaly that in those the lowest quintile, the most deprived quintile, that actually certain people in those quintiles of ethnic origin did better. Now, who were they? So, as you said, they weren't Pākehā. No, they were not white Anglo-Saxon Protestants. Well, I know Pākehā doesn't mean that, but they weren't. So who were they? The two groups that, despite being in that deprived, either the figures are wrong and they're not disclosing, or we don't know their income and all that and all the other figures, or in fact, there's something wrong with the way in which we look at things. And there were two very prominent ethnic groups where they were healthier, happier, and more resilient than the population despite being in that group.
I'm presuming, Mansel, that they are from cultures where there's a strong cultural support and identity. There's a strong sense of identity within those groups. I'm not sure which one in your context they may be.
You were Jewish, okay? There weren't Jewish people in these groups. There were, but they didn't stand out. But if you went to Whitechapel, East End of London, 100 years ago, most of the people living there were Jewish, having been pushed out, pogroms and all that sort of stuff. And yet they were resilient, they had a family commitment, and yet they didn't earn more than anybody else. They were equally deprived. So it's people like that. But in this study, it wasn't Jewish, because actually in the end, what do they say about how long does it take to get to Hampstead, which is a very nice part of London, from Whitechapel? 2 generations. Right. But it's true.
By a golden screen.
By a golden screen, exactly. then that's a dead centre of the Jewish people. Come on, who are they? Come on, you do know. Think about it.
Asian.
What sort of Asian?
Chinese and Indian.
Chinese, number one. They really no matter what, they were still in that group. They weren't the happiest, but they were the most resilient and the most outgoing and committed to their family. But there was another group that were also happier than the rest. A group that you would not think of. There weren't many in that. Well, yeah.
Muslim?
No.
Bengalis?
No. Kiwis? No, they weren't. And no, the other group actually were Hindus. People of Indian subcontinent origin, not Pakistan or Bengal or whatever. And you know, so there's something different. It's not just solely due to you know, these decoration things that we look at and we put people into groups, which is a bad thing anyway. There is something else that's going on, and you're quite right. You know, there are other issues that make a community the way it is, and part of it is the way we think about it and the way we make those people think about it. But it's still a problem. All I'm saying is, you still got to address the fact that, you know, health inequities occur with everyone, and they can be usually addressed mostly by the same techniques, except you've got to look for the differences and exploit the benefits that, you know, we've learned from other ethnic groups in the UK. I'm talking about. So okay, so these are the challenges, and we put in the one about the possible issue of ethnicity, not here so much, but everywhere. Okay, now that's all good. We did that within the 6 weeks, okay? But so what? So what? You know, everybody, if you look at the papers, those challenges have been around have been articulated for 25 years. They got worse lately because of the recession. They got worse because of the projections of people living longer, the demographic time bomb, which you haven't put in there, but it's there implicitly. Why haven't we done anything about it? Seriously, why haven't we done anything about it? It's a tragedy. Every year you see a report from the Chief Medical Officer of the UK or Wales or whatever, and it says the same things over and over again. Oh, this is happening. We've got a little bit better in this group. We're doing good with hospital-acquired infections. Great, ticking the box. You know, are we changing anything really? No. So why aren't we doing that? Because that's the real challenge that we have to address. That is it. And you've mentioned one of them at the backside, haven't you? Culture. But why should culture be an Indian? Why should the word? What does culture mean? Somebody define culture for me. No, not you. He's written books about it. I'm not asking. What do we mean when we say the culture of a society?
One of the basic assumptions that that inform the way we go about the way we live.
Yeah.
Norms, beliefs, behaviours, that kind of stuff.
Yeah, it's the commonly accepted beliefs, norms, goals, values, and expectations of a society. Doesn't mean to say that everybody has them, but if you go in there, that's what you find, and that's what defines the culture. And it can be a good thing or it can be a bad thing. Well, why is it a bad thing? Why has the culture stopped us progressing? What is it? I mean, culture is good, isn't it? You know, in one sense, it's you're a cultured person, you know. What is in culture that actually prevents us getting ahead?
Powerlessness, learned helplessness.
Powerlessness, we'll put that. Powerlessness, we put culture, and we put powerlessness and learned helplessness. Excellent, I think that is.
Mansel, I wonder, as a non-medical person,
Please.
number one,
Yeah.
is community involvement.
Okay.
I have the privilege to mix with a huge number of medical people.
Mm-hmm.
I don't think we have a community involvement. We do it well in certain areas. You are doing well. But unless people understand it, you're never going to get anywhere, speaking as an accountant, about that financial problem.
So,
The Ministry of Health can sweep it under the table, but if there's a community involvement, a community of understanding, the culture coming through, then you will get people you know, pressing for change.
Yeah, so it's
you talk about health inequalities, you talk about all the other challenges people have got, but you've got to get the buy-in for the community. We have a kids' hospital, you know, Starship and Kids First, where, you know, there's a wonderful tear-jerking story. You get community involved.
So it's community engagement.
I think so, yes.
Yes. Okay. That's
And that leads on to the pressure.
Yeah.
We
So it's
can
that,
say.
the barrier then is of it. The Indian culture, there are barriers, could be the fact that that culture is largely powerless and has learned helplessness. It doesn't assert itself, right? Not because it wouldn't do so, but the circumstances are such that people don't assert themselves. And then the lack of community engagement involvement makes it difficult. Okay? What else about culture is
Can be exclusive.
exclusivity? Yeah.
No.
Exclusivity. And, to use another word, which can be used in its right context is okay, but in this context is not, and that's elitism. People believing they're better than other people.
Tribal.
Yeah. And where's the worst tribal elite community? The healthcare profession. Yeah. And amongst those, the doctors. I can say that, right? Yeah, you can say that. You know, I know this doesn't happen anymore. When I was a medical student and went on the wards, and he was in the same hospital at one time, in Whitechapel again. You know, he used to say, I wouldn't tell them that. They won't understand, or you'll only upset them, or you know, they should really know they're going to die in a week's time. It's not good for them. Not good for them. They're going to be dead in a week's time, you know. But that thing, that exclusive culture, that elitism, that them and us type of approach. Okay, well, one more, and then I'll ask you why it is that's
Reinforcing status quo.
yeah,
No,
really,
people-
yeah, of course, yeah.
People care, but do they care enough to want to change?
Yeah. So we come into the things that I mentioned the first time I came here about change, right? The fear of change. Yeah. The change is never going to be good for me. Yes, I understand it could be good for everybody else. I think it might even be a way forward, but I still got that niggling feeling that I'm going to be the butt of it. And I won't say that outwardly unless you do it in a sort of, and we do these anonymous interviews now where people do say, well, I know that that's a good thing in healthcare, but my job may be at risk. Because if you're doing it better and more effective, you can do it cheaper, and you can do it with less people, well, it means that I may not have a job. Instead of thinking positively, that's not so. In fact, what you can do is make that person more likely to be responsive to doing things in a different way. You know, but it's right. And that comes out. The workforce thing. Yes. Workforce. Okay. We'll add one more, and then we can go to the next step. What do we lack? What do we lack in taking this forward? If we're going to meet these challenges, you said why culture and all that sort of stuff prevents taking things forward in this way, prevents progress. So how can we overcome that? What have we got to do? What do we have to do to change the status quo? You can't say that. But you may have to. No, come on, let's think about it. Let's think. How do we do? How does change happen?
We have to build a shared sense of what the current state problem is. We've got to get a shared database of what the current state is and understanding what we need to change. We need to have unity of purpose around it.
And belief in possibility.
Belief in possibility. Belief that it can happen. Yeah.
Believe the shift. To shift.
Shift what?
Well, you've got to know what the new vision's going to be. How are you going to get there?
Vision.
Dream or plan.
Make it
Believe in
personal.
possibility.
Sorry?
Make it personal.
Make it personal. You mean get the person involved. Is that what you mean by that?
Just that
So,
people
what
don't
do you
change
mean?
because of policy or guideline or anything like that. They change because of a change in me. And if you get in a
people to respond at that level.
Yeah. What you mean is, what is in it for me? Really? Is that what you mean?
Yeah,
That doesn't got to be selfish.
but it is that thing that it's going to be motivating you to make people want to change.
We've got motivation down there, motivating and desire to change, okay? Okay, right. You still haven't done another one, which I think, oh, how is this going to happen? It's going to happen overnight. It's going to happen tomorrow. Is somebody going to come along from a cloud and say, oh, everything's nice now? Yeah.
Educate and empower.
Educate and empower. All right, back to this gentleman here.
Have a plan.
Have a plan.
Create a sense of urgency.
Urgency. Okay. Well, why the hell aren't you doing it then? If you know what you're doing, you know all this, right? I took 3 months to get here. You said it in about 10 minutes. But you're missing something.
You have to make some space, and you have to make some time, and you have to bring people together for these kinds of things to happen, because they don't happen. They won't because people are too busy. So you do have to.
But what makes them happen?
Leadership.
Leadership, for Christ's sake. So sorry. I meant that religiously. Hallelujah. Right? But leadership is so important. You use it all the time. You read any treatise that you can possibly get on how to change. What I say? You need to have leadership. Leadership is important. Why? Why is it important? I talked about leadership when I first came here, and I said something like, leadership to me is the capacity to motivate a group of individuals to a common end. So common means they've got a shared vision and all that stuff. But you've got to have something, someone, and it hasn't got to be a person, it could be a group of individuals who are actually prepared to pick up the baton, as the French Alaskans say, baton, pick up the baton, as we say, and run with it. And as I said, if nobody tells you to stop running, you keep on running.
Just if I may, one beyond that, it's not just leadership, it's ownership as well.
Leadership and ownership, absolutely.
It's also followership.
Followership?
Yeah. No point having
You hit on a very important issue. Unfortunately, leadership has been associated with elitism. Okay? I can say it here, but I was asked to address a group of Germans here on leadership. Very difficult to talk to Germans about leadership. Because it does not mean the Führer. It does not mean I'm Reich, I'm Volk, I'm whatever. It's not about elitism. Most of the leaders that I know are not thought to be leaders. And in fact, when we've done a session recently in Cardiff, when we had a group of people together to talk about the people that they considered leaders during history and the people that they considered who are leaders now. And leadership costs right across from people who are heroic leaders right through to people who have actually been working in the background and with a group of other people who are equally leaders took forward a lot of reforms. I mean, the major reforms in public health. You have names coming out. That guy Balfour's, what's his name? I never can remember his name. Bazalgette, okay? Bazalgette. He's the guy that designed the London sewers, and that was the single most important benefit to public health, to health, that there's been in the United Kingdom. But he didn't do it alone, and he was a very quiet man, and he worked with a lot of others. And one other person whose name is a fellow called Edwin Chadwick, if you may have heard of him. He was an awful man, a nasty individual, who went around with a long stick, with a silver flame on the top like this, and hit people on the head. He was an awful fellow.
There's Martin Chadwick's that over there.
Oh, was it an ancestor?
Yeah, second cousin.
I didn't know that. And you bought me a cup of coffee? We wouldn't have done so for you. But Chadwick, no matter what his personal qualities were, he actually put it on the map. And if it wasn't for Chadwick, Bazalgette wouldn't have gone anywhere. So there's all this interaction when we talk about leadership, but we do need it. And that leadership must be looked at in some great depth, not just say we're going to have a leadership academy, which I hope we're going to have here, but what is it all about? Who should be involved? How should people be recognised? is leadership, as I say, are you born to be a leader or can you be developed? Both. So there are some people who are born leaders and others who don't even know that they've got this leadership quality. And leadership, I wish we could think of another word, because it does still ring of, you know, the leader and the follower. No, they're not, because they're all working together as well. Okay.
Buildership? Buildership.
Buildership. Tell me what that means.
Building better systems.
Building better systems.
That's just an
So
alternative.
that's, no. Is that the ability to conceive of it, either yourself or with others, you know, constructing it analytically, or are you talking about something that is not theoretical but actually doing it? So it's building relationships.
It's the whole thing. Building networks.
Yeah. And of course, we put down relationships because I think that's very important. Okay, so what I'm trying to get at is we identified what the future challenges are. We said, well, they can be overcome by changing culture. Now, I didn't say that, you did. And we've said more or less what culture is to some extent. We said also that it also needs to be done by leadership, some motivation, getting people together. That's fair enough. That's going to help change. Is there anything else that's going to help the change? From now to tomorrow, what else do we need to guide us on our way?
We need a plan.
We need a plan.
We need clear objectives.
We need clear objectives.
We need good measures to tell us we're making progress against those objectives.
Okay. Plan, strategy, whatever you want to
And we need capacity to do it.
Right. We need capacity to do it.
And capability.
Right. We need knowledge as well, don't we?
Yeah.
So which fits in with what you're saying.
Yeah.
So we need knowledge, but we need the right kind of knowledge, and we need to manage that knowledge. So now knowledge management model, we need that. So I know there's lots of other things, but we did come up with those three as top sort of things, and we said, okay, how do you go about doing that? And with regard to the culture change, that's something that's not going to happen overnight, and we want to have something whereby it can help people to move from one feeling, one belief, one attitude to another. But the worst thing you can do, isn't it, is to try and force people to change their beliefs and attitudes and motivate them. So what we came up with, and we'll read it in your the case of change, is actually what we've called, in working terminology, an impact of change assessment. Now, we're all familiar with health impact assessments. When something is being done, whether a particular community or anywhere else, whatever, and that could have an effect upon the health of that community and well-being of that community, now it is obligatory in the UK that you undertake a health impact assessment. And that means engaging with the community, talking to them about them of what it is that's going to happen, getting them, I can't remember what it was now, you said about ownership. Is it Mary, is it? Yeah, ownership. Because you can't change people's minds by just going on to a session and then saying this is the way we should do it, and you're going to do it because that's the way it should be, because all these famous people have said so. You've got to get them to formulate it forward. And health impact assessments, yeah, come to that. She thinks, I don't know what I'd do without it. I wouldn't be able to live. I don't know, but seriously, I don't know what I would have done without it. Anyway, so you've got to have this sort of, I've lost my strength. What was I saying?
You were talking about
Who
impact
interrupted me?
assessments.
Yes, impact assessment for change. And we done before I left, we did a bit of thinking about that, and I was in touch with people who are very highly regarded in health impact assessment to say, was this a daft idea? And they said, no, it's a spectacular idea, and somebody's already thought of it. So we did find a paper, which I forwarded to you this week, which is talking about the very concept that we came up with, and that is, how do we change things for the better? For the better, that's another thing. An improvement of, forward-looking improvement by getting people to work together, have a common view, have a common vision, have a belief, that this is going to work. It's all the things you said. And in addition to that, are committed to doing it. You know, we all give lip service and we don't do that. And the reason is we weren't involved in making the decision. You know, we didn't. The lady over there, whose name I don't know. Maggie said it. What's in it for me? And it's not selfish, you know. How did I contribute? I want to be part of this. I want to be an owner. I want to be an owner. And so I've advocated that one of the things that should be done and lead the world, seriously, we use that a lot as well in County Manukau, is actually you can do it. You know, you can do it. You can be the first people to actually conceive of this theoretical, because the paper that's been produced is one which is a theoretical one. You can be the one to do that, and I hope I could be able to help you and Pam, Jonathan. We can help in getting you to do that. There's another thing as well, and that is knowledge, we said, opinion, and a sense of that people in authority, people who are well known, people who are respected, are prepared to endorse what you are doing. It's no good doing something which is going to be unfeasible. It's no good doing something if you're going to be a laughing stock for doing it. And it's no good doing something if there's a big elephant trap down the road which you haven't thought of. So one of the roles of this independent commentator, which is the other paper that we've written, is just that. It's based upon this thing called the Bevan Commission, which I've spoken about before. But as a summary, Bevan Commission is named after Aneurin Bevan, who was the architect of the NHS in the UK. And he set out certain principles for what a health service should look like and why. You know, it should be universal, should be comprehensive, and it should be as free as possible at the point of engagement. And those principles are these first three, but there are many others which we've described in the Case for Change, which are modernized Bevan principles. And when Gregor, who unfortunately is unable to be here today, he was invited over because he's now a member of the Bevan Commission in the UK. He gave us a talk about what he hoped would happen if the recommendations that we made in the paper on independent commentator actually were seen to be were realised in County Manukau. And it would be a group of people who would be independent, and we had a big argument about what that meant, but it's one of those words like belief and happiness. You know what you mean when you say it, but when you try to define it, you find nobody's independent of anything. And impartial, and nobody's ever impartial, it's a relative thing. You know. But these people of high regard, experts, in inverted commas, and that's derogatory sometimes, but experts, people who are listened to, people who are key opinion makers, people who actually have driven change and made an outstanding contribution to the world of healthcare. But when I say health, I know Doon will agree with me and many others, we're not just talking about healthcare and healthcare professionals, we're talking about housing, we're talking about transport, we're talking about demography in general, we're talking about geography, we're talking about an education, which is one of the first things somebody brought up, an education. So we want people on the panel who can actually commentate independently on that, and looking at the case for change and the recommendations coming out of it, looking at a paper that will be coming up, I hope you don't mind me mentioning, shortly on a leadership academy, embracing all the principles I've talked about now, a non-elitist thing, a general thing, a thing which focuses on what's called distributional leadership. The whole community, no matter where you are in that community, contributes towards the leadership of that organisation. That's the next paper that Pam, I'd like you to just mention at the end, if you wouldn't mind. Well, this panel, which we hope, see, I'm saying I again, that's what's wrong with most of us, we're always talking about I. But we want to that. And the principles of it are that it will be independent, it will be impartial, it will be made up of people across different communities. It's described very, very fully in the paper that some of you have got already, but it's on the website. And it's based upon higher, and I can't use the word higher in this sense. I feel that that committee panel, if it is shown, this is my own personal view, I haven't talked to Geraint about it, or Greg, or anything like that, but Jonathan knows my views. If that panel is as good as it should be, and if it goes along the same trajectory as in Wales, then that panel can have a say in the national policy. Okay. Now, when I said that first, in a certain place in Wellington, what? You mean you've got an independent panel? You must be out of your mind. We can't have people second guessing us. That's what they said then. Since then, and that's 3 years ago, they actually thought, well, it may be an advantage here, you know. It may be a draw upon people. It may not be a threat. It may be a help. And that's what this independent committee is. It's a help. You get access to those people's views, minds, networks for nothing, because we're not paying them. They should be honoured to be part of the panel, as they are in the UK. So that's, I'm nearly at the end, so I won't go any further on that. We can talk about it, though I'm happy to stay as long as you like. But Pam, would you just like to say just a little bit more about the leadership?
Yeah. In Geraint's covering letter that introduced the white paper series, he talked a little bit about the third in the series, and it's really a paper around a leadership academy and what a fairly large literature review about what does best practice look like in leadership development, as both in healthcare and in business, because there's lots to be learned from leadership development in business. And so that is being written up as we speak, and also then a model that we would take forward as the co-Alatea model of leadership development. And so, I don't know, in the next probably couple of months, Jonathan, we'll finish up on this paper and get that out to you. But this week I'm having meetings with quite a few of you to discuss a proposed model and to discuss some of the findings from the literature review, so that, because we really do want to hear from people before we go forward with a proposed model. So that's what we're up to now. That'll be the third in the series, and that will really sort of cover off at least the leadership and the independent commentator in white paper. So it'll be kind of it'll be quite a bit like the independent commentator. It'll be a very practical paper that gives you background and then sort of a how-to.
Yeah, and I think, you know, okay, it's difficult in an hour to get all these things together, but I think we have done that to some extent. You did actually identify within 10 minutes what the things, challenges were, and you actually identified what we think are the ways forward. And we mustn't go wrong. We mustn't lose here, and it must be sort of inclusive. That's the word, I think, because so many people I've spoken to here, when I was here, and at home, and in British Columbia, they say, yeah, this is all very well, but actually, it's not going to happen. It's just not going to happen. You know, nobody's going to listen to me. I don't mean me, I mean listen to them. And they won't listen to you either. They'll say, yeah, we're going to do it, wonderful stuff, but actually it's not going to happen. Well, you have got to make it happen, because it isn't the leaders among you that do that. You're all leaders by just being here, I think, and listening and talking and being involved. You've got to make it happen. And before my last phrase, Doon, whose words I value, is going to say something.
A piece of comment and thinking, you know, maybe speaking out of turn, but in terms of going forward and taking people with us, I think it's really important in some of the languaging to be acknowledging what people have been doing up till now. So I think there is a tendency in this kind of change space to be talking about everything that needs to change and all the stuff that we have to do going forward. And sometimes people can feel quite disparaged, really, I think, for the huge amount of work that they've already put in. And so I just think that's really
important. You're absolutely right. And I focus on change, but in the original Bevan Commission paper that started me thinking this way, that we put together, and it's mentioned in the case for change, the enormous, and it is enormous progress has been made in Counties Manukau and in New Zealand, you know. They've got to be recognised, because you can't just say, are, as many people do, why do we need to change? You know, we're doing well. It's not because we're not doing well, it's because we can do better. I mean, that's what matters. And we need to, because we can't stay where we are. But actually, I mean, the thing that impressed me greatly about New Zealand was the, get it right in a minute, it's Prescott nurses? No? Plunkett. Ah, well, Prescott and Plunkett were both ministers at the same time. So Plunkett, I mean, the Plunkett nurses, I've taken that, I mean, it's not rocket science, it's just good stuff. And I've taken that back because we're looking at our health visitors, you know, something, and how do we take that forward in the UK? And I think we couldn't do better than just looking at what's happening with Plunkett nurses and how they've been developed here in New Zealand. So that's a general national thing, but many things, including Kawawatia, let's be honest, you take it for granted now, but together we pursue excellence in health systems and patient care. That's all very well as a saying, but it's got to mean something. And the fact is that points to not saying that what we're doing is bad, it isn't. What we're doing is as well as we can, but we can, with knowledge and commitment and enthusiasm and engagement and ownership, we can go further. And I've got, just to show that I don't always just read medical things, I read books on my Kindle. And I've been reading all the Shakespeare stuff again, and some Charles Dickens. And this phrase is a very telling one from Act 3, Scene 3, Julius Caesar. What is it? Said by Brutus to Cassius. Very important. Oh, do you know which one? Can't hear you. No, he'd already done that. No, this is the phrase many people quote, but don't quote it all, and all is better, you know. There is a tide in the affairs of men, right? Taken at the flood, which leads on to fortune. You got the moment, grasping enough. And people think, that's enough. But what is it going to say? Omitted, that is, grasping it, all the voyage of their life is bound in shallows and misery. That's better. And then he says to Cassius, on such a full sea as we now are afloat, we need to take the tide. I end, quod erat demonstrandum. I don't know what it means, but they always say. Thank you very much.